Assalamu alaikum everyone. In this video we are going to discuss very important topic, that is AV nodal blocks or heart blocks. It is classified into first degree, second degree and third degree AV nodal blocks. So let's start with the first degree block. It is characterized by prolonged PR interval, as we know that PR interval in the ECG shows the delay in the AV node. But here in this case, due to defect in the conduction system or due to blockage, there is a prolonged PR interval. Normal range of the PR interval is from 0.12 second to 0.2 second, that is 3 to 5 small boxes. But in the first degree AV nodal block, it is more than 0.2 seconds, that is more than 5 small boxes due to defect or due to conduction defect. And each P wave is followed by QRS complex, and due to blockage there is no missed beats in the first degree AV nodal block. Now come to its causes. The most common causes AV nodal diseases: increased vagal tone. This increased vagal tone is more common in the athletes people, and inferior wall myocardial infarction, electrolyte imbalance. So these all are the causes of first degree AV nodal block. Now come to its management. Its management: if the patient is asymptomatic, then there is no need to give any treatment or any interventional procedures. But if the patient is symptomatic, the best initial therapy is give the patient atropine. As we know that atropine is anticholinergic drug, that it increases the heart rate of the patient. So it has positive activity in the AV node, so it increases the heart rate, or it improves the conduction in the AV node. So atropine is the best initial therapy, but the most effective therapy is implant the pacemaker in the chest. Pacemaker is basically, it is a device which is implanted in the chest of the patient and improves the contraction of the ventricle. So it detects the slow beats of the heart and it improves the contraction of the ventricle. So it is very important to eject the blood into the aorta. So this pacemaker is the most effective therapy in case of AV nodal blocks. Now look at the ECG of the first degree AV nodal block. So this is the ECG of first degree block. As you can see here, that PR interval is more than 5 small boxes, that is prolonged PR interval, and after each P wave there is QRS complex, then each P wave, then QRS complex. That there is just a there is no there is just a prolongation of PR interval, but there is no missed beats in first degree AV nodal block. Now come to the second degree AV nodal block. It is characterized by drop beats, that the severity is little bit more than the first degree AV nodal block. So the some impulses from atria fails to conduct into the ventricles due to blockage. It is classified into first degree Mobius type 1 and Mobius type 2. So the second degree heart block is classified into Mobius 1 and Mobius type 2 block. This Mobius type 2 is much more dangerous than type 1 because of the chances of cardiac arrest and sudden cardiac deaths are more in the type 2 second degree AV nodal block. Let's talk about Mobius type 1 or Wenckebach's phenomena. In this case, it is characterized by the progressive lengthening of the PR interval and then there is a beat drop. Now look at this ECG of Mobius type 1. As you can see here, there is progressive lengthening of PR interval. This is the PR interval, and here as you can see here, it is lengthened. That is more increase in the length of the PR interval in the next PR interval, and then there is a missed beat. So there is progressive lengthening of the PR interval and then followed by the missed beats. This is called Wenckebach's phenomena or Mobius type 1 second degree AV nodal block. So this is the ECG of Mobius type 1 block. Now come to its causes. The most common causes are AV nodal diseases, which may be due to inferior wall MI, myocarditis, mitral valve surgery, and increased vagal tone in the athletes people. The management includes, if the patient is asymptomatic, then no need to give any intervention or any treatment. But if the patient is symptomatic, as in case of first degree block, we have to give the patient atropine first and then followed by pacemaker implantation. So this is the treatment of Mobius type 1 second degree AV nodal block. Now come to Mobius type 2 second degree AV nodal block. It is characterized by drop beats, without lengthening of the PR interval. As you can see in this ECG, second degree Mobius type 2 block, there is no progressive lengthening, unlike type 1 Mobius. As you can see here, there is constant length of the PR interval and there is drop beats. So it may be 2:1, that after one P wave, then after two P waves, then one QRS, and then maybe three P waves and then one QRS, because of failure of conduction from atria into ventricles. So this is the ECG of Mobius type 2, that constant increase. That is, there is no increase in the length, but there is constant PR intervals along with the missed beats. So come to the causes of Mobius type 2, that abnormality in this case is in the Purkinje fibers or in the bundle of His. The other causes includes anterior wall MI, degenerative diseases in the conduction system of the heart, infiltrative diseases like sarcoidosis, and aortic valve surgery. In this case, as it is more severe and can cause sudden cardiac death of the patient, so whether the patient is asymptomatic or symptomatic, in both these cases, the permanent pacemaker is the treatment of choice in case of Mobius type 2 second degree AV nodal block. Now come to the third degree AV nodal block. In this case, there is complete AV nodal block, that P wave has no relationship with the QRS complex, that there is no relation between the activity of the atria due with the ventricles due to complete blockage. The causes includes myocardial infarction, cardiomyopathy, severe hyperkalemia, valvular abscess in case of infective endocarditis, and the infants defect in the infants of the mothers with SLE, that is systemic lupus erythematosus, sarcoidosis, and Chagas disease. So these all are the causes of third degree or complete heart block. Now come to the clinical features of the third degree AV nodal block, which includes syncope due to reduced cardiac output because of ventricular asystole, and dizziness, acute heart failure, and Canon A waves. This feature is very important. These are basically the waves visible in the neck due to large volume pulse. So from the compensatory increase in the stroke volume, because in the third degree AV nodal block, there is reduced cardiac output due to asystole and there is decreased perfusion to the organ. But due to compensatory contractions, there is increased stroke volume. It is a compensatory mechanism. So due to this increased stroke volume, there is large volume pulse visible in the neck veins. This is called Canon A waves. And the next important feature is Stokes Adam attacks. These are basically unconsciousness attacks without warning due to the episodes of ventricular asystole, that decreased perfusion of the brain due to reduced cardiac output can cause unconsciousness, and these are called Stokes Adams attacks. Now look at the ECG of the third degree AV nodal block or complete AV nodal block. As you can see here, there is no relationship between the P waves and the QRS complex. So this is the ECG of, like here there are two P waves and then this is the P wave and then QRS complex. There is no specific relation between the atria are contracting separately and the ventricles are contracting separately. There is a no relationship between the contractility of the atria and the ventricles. So this is AV dissociation. This is the ECG of third degree AV nodal block. Now come to its management, whether the patient is symptomatic or asymptomatic. In both these cases, permanent pacemaker implantation is necessary, or it is the treatment of choice in case of complete heart block or the third degree AV nodal block. So this was whole about the AV nodal blocks. Thank you so much for watching this video.